In this next section, we're going to pick and start with 5-FU, or 5-fluorouracil. This is an old drug. It's an anti-metabolite. It is cell cycle specific. It's used mostly for colon and breast cancer. Can be given IV, push IV, piggyback, IV infusion, any of those routes. Some of the things that we need to watch for with 5-FU are bone marrow suppression, stomatitis. We've talked about that quite a bit. We need to be aware of what we would do to treat that. Alopecia, obviously, and photosensitivity. This drug inhibits DNA and RNA synthesis. You definitely want these patients to avoid sun exposure due to photosensitivity, and we don't want to give this if the white blood cell count is less than 3,000. Remember, an anti-metabolite is simply a chemical that inhibits the use of a metabolite, which is another chemical that's part of normal metabolism. This drug actually works by causing death of rapidly replicating cells in a specific phase of replication. Again, not that you need to know that, but most of these drugs work that way. In addition to the cancers listed above, this drug can also be used for rectal cancer and for pancreatic cancer. Methotrexate is another anti-metabolite. It is cell site specific. It's used to treat leukemia, breast cancer, head and neck cancer, lung cancer. Can be given oral, the piggyback, IV infusion, IM, intrathecally or interarterially. It causes bone marrow suppression, stomatitis, nausea and vomiting, nephrotoxicity, photosensitivity. The antidote for this drug is leucovorin. One of the other things you need to encourage your patients that are on methotrexate therapy to do is have yearly eye exams, because that is one of the things that is commonly reported with this is the damage to the visual fields. This drug actually interferes with the synthesis of folic acid, so you want to make sure your patients aren't taking a folic acid substitute, or supplement rather, while they're on the methotrexate, because what's going to happen is you'll eventually overload the patient with enough folic acid that cell replication can still continue to occur. You will see some patient groups that are on methotrexate use folic acid. Typically it's for autoimmune problems that they're doing that, not cancer treatment. So again, we need to be evaluating this patient's diet, making sure that they're not taking excessive amounts of folic acid. It is also an immunosuppressant, so keep that in mind as you're taking care of these patients. As always, good hand washing, private room if at all possible. For all the other side effects that go with these, that's always something that we want to be looking for our patient. Guess what? This one works by causing death, rapidly replicating cells, especially malignant cells that are being replicated in the body. Doxorubicin, it inhibits RNA and protein synthesis. It's a vesicant, so we need to make sure that when we're infusing it, that we understand what's going on there. It's broad spectrum use, but mainly it's used in leukemias. It can be given IV push, IV infusion. Causes alopecia, marrow suppression, nausea, and vomiting. Flare or a red streak with this drug is a side effect that you need to be aware of. Flare is different from extravasation in that flare typically disappears in 45 minutes or less. If your patient has a flare reaction, some of the things that you can use to differentiate it from extravasation is you'll look and it will actually follow the vein up the patient's arm, whereas extravasation typically tends to spread in a circular pattern. This goes more linear. Some of the things that you can do is you can use normal saline to flush the med through the line and reduce the flare. If it becomes problematic or the patient repeatedly experiences flare, you may see your patient pre-medicated with a drug like Benadryl or a antisteroid also. Flare is not necessarily a reason to stop the infusion. You need to monitor it though and ensure that it is indeed flare and not extravasation. It is cardiotoxic. It can cause necrosis if you do have extravasation. They can usually have red urine. That usually starts in a couple of days or so, or a couple of hours after the med. Look at the drug sheets that I put out on Blackboard last night for more information on that and clarification. I don't have that one in front of me right this moment. One of the things that you need to monitor with this drug is tachycardia. That could be something that your patient presents with. Again, this one causes death of rapid replicating cells. It's used for breast, ovarian, bladder cancer, malignant lymphomas, and leukemias. Extravasation, once you realize that this is occurring, or you believe that this is occurring, especially with a vesicant, you need to stop the IV. Again, if indicated, we want to aspirate from the catheter and the site and consult other services as needed. And what you'll see here is 2 different degrees of extravasation that have occurred to the patient, so you can see just how damaging this is. Secondly, another thing that we have to realize, that these areas have opened the patient up for further infection. Their healing times are delayed because these medications have affected that cell cycle synthesis. So we're not doing these patients any favors at all by doing this to them. Not only that, but I can only imagine that it's quite painful. Let's talk about vincristine right quick. It's a plant alkaloid. It is a vesicant, so we need to watch that while we're infusing it. It is cell cycle specific, and it must be IV infusion. It does not readily cross the CNS, so it's not going to be effective in certain types of cancers. Side effects: alopecia. The dose is limited by the amount of peripheral neuropathy it produces. You often see mental depression and headaches with this particular drug. They'll get loss of Achilles tendon reflexes as viewed as the first sign of this neuropathy. So you need to keep up with those deep tendon reflexes. We talked about measuring those before with other disease processes, so you might want to refer back to those notes. Cellulitis, if tissue necrosis because of extravasation occurs, and they can have hyperuricemia. Cell replication is stopped with this drug. It happens at a very specific phase of replication, occurs in the metaphase. Again, it causes death of rapidly replicating cells. Little to no effect on the bone marrow, and it does have immunosuppressive properties. It can be used to treat Hodgkin's, leukemias, neuroblast, malignant lymphomas, Wilms, and others.